Devaraj from Cardiff fracture disease. So the FLS roles, nurse role, initially we do virtual FLS assessment. Patient identification and assessment is a very important one. We do early identification with patients who have low trauma, fragility fractures, and then we do conduct both virtual and face-to-face clinical assessment and giving more awareness to the patients. Then commence treatment if indicated by FRAX. So we have, our service have given us a nice new FLS pathway. So we aiming to provide early osteoporosis screening and treatment in accordance with full FLS pathway in partnership with patient. So while we do the assessment, we like to do the FRAX, and if it indicates to start on treatment, we encourage patient to have a treatment. False risk assessment. So this is very important. We do it for age 65 years. We do full risk assessment, and also if they're less than 65, they're quite vulnerable, we refer them to local falls service. And arrange DEXA scan if indicated. So while we do the assessment, if the FRAX indicate this patient needed DEXA, so we carry out initial screening and offers DEXA scan if indicated. And arrange FLS follow-up in 60 weeks and 52 weeks. So during FLS, during the 16 weeks follow-up, we monitor medication and ensure patients are taking it correctly. And we refrax with bone mineral density, and sometimes we change the treatment if it indicates. So the challenges we face in FLS nurse-led clinics is quite few only, but we're not too bad at the moment. Target to identify all people over 50 plus who has fragility fractures. Currently, we send letters to over 75s in women and over 80s in men to say that we're going to refer them to the GP for further treatment plan. And we're hoping to alter in future as well. Time consuming is the main thing is to identify patients from various places, especially we do from trauma and orthopedic list. So our management team is quite grateful to getting patients from duplicate and highlighted to FLS service. Radiology reports. So we get referrals from radiology, like instant vertical fractures every 3 months. But at the moment, for some reason, we occasionally get those. We're going to improve that in future. And the referrals we have currently, they're doing e-referrals to FLS. Occasionally we get e-referrals to our doctors and to other members of the team, and they direct to FLS. For current system is like this. And the last thing is multiple pathway and criteria to evaluate, triage and make a decision. So we got a comfortable protocol now made by our lovely consultant. He made a full FLS pathway to make the right decision, to give the right treatment to the right patient.
Now using Betsi Cadwaladr as an example, as the regular PCU fracture liaison service, we are able to systematically identify and manage patients and outpatients for the west and central areas of the health board through case finding and an inpatient FLS presence on the TNO wards. We also capture patients on a weekly basis, ensuring assessment and initiation of treatment is carried out. We benefit from a good collaboration with the MGT team in primary care and secondary care to implement our treatment outcomes. We also work in partnership with our local hospitals to support treatment provision, including the rural hospitals in North Wales, particularly in rural areas. In terms of our challenges, currently we do not cover east of the service, and as many health boards are experiencing, we're also having extended access scan waiting times at present. Another prominent barrier we can experience can be variable clinician engagement and resistance to practice change. There can be, in some cases, perception of osteoporosis management is lower priority compared to acute fracture care in the acute environments. Conversely, in some cases, there may be variable patient engagement with non-adherence to treatment and follow-up. And next, how can we be more effective, or points for improvement? We could benefit from improved IT systems to speed up our DEXA scan reporting and increase vertebral fracture identification within our new radiology system. And subsequently, these slides were made earlier in the year in February, and we have now been able to achieve this. Additionally, a dedicated pharmacist within our unit and more admin support is also warranted.
So the last one is opportunities for the future nurses leadership. So we're trying to work to collaborate, working with the primary care team. So FLS nurse-led, using the data to collaborate with the team, sometimes to get better ideas. And for education and professional development, we're going to start to request X-ray and develop more skills in future. And developing expertise to handle data and research. So we use database to collect more information to raise the KPIs. Sustainable workforce to provide a person-centered care and overcome health inequality, so we get more confidence and be quite independent and empowered. So the last one is to achieve 80-50-80 target, improving quality. So identifying, we keep routinely identifying 50 plus patients who suffer with fragility fracture, that's 80% we aiming, and we ensure minimum of 50% of identified patients are safely commenced on appropriate bone strengthening medication, and we follow up and monitor at nearly 80%. Thank you.
Thank you.
Thank you both. Very encouraging talk to see how these principles are fleshed out in clinical practice with the challenges and various opportunities.